box on your sign-out sheet. And then at 2 a.m., you're just cruising through the unit on your way to the bathroom. And you hear like alarms going off and people running back and forth. And while they were bathing this guy, turning him over, later that night, the trach popped out. And the guy's all cyanotic and blue, and sats are 70, and people are screaming back and forth, and you kind of run into the room. What do you do? You gotta be faster.
Stick it back in.
What's that? Stick it back in.
Can you stick an ET tube in the hole?
Great and fatally wrong answers.
Okay.
But that's the answer that you almost have to give. And that's why I asked the question. And because you stay away from that fresh trach site. Why? Because when you put it orally innovate. Yeah. So the trouble is, if you try to, it's so tempting. You have a tube and you have a hole that the tube belongs in. You know, it makes so much sense to put it in there, but you don't because the tissue planes aren't fixed yet. So what you do is you jam it in, and then you're bagging them, and it's not getting better, and then there's the Michelin man because of pneumomediastinum and hypotensive, and it's terrible. So what happens is you go down, you're either under the skin or in the soft tissue plane, or it's just not, the hole isn't where in the trach yet at that point. 3 weeks later, a chronic nursing home guy has, he can take his in and out, but initially, stay away from that hole, and you oral trachally intubate, and you just cover this hole so air doesn't come out. And the reason I mention that is at least once a year we'll have a death. I've seen death due to that. I don't know if you've ever seen that before, or trach misadventure that you can share with the group.
We had a guy it sort of popped out.
Yeah.
And but he didn't look too bad, and we couldn't tell quite what was going on.
It's really for Santa Claus.
We stuck a bronchoscope down.
Okay.
And what ended up happening is it was sitting like, if this was the trachea hole, it was sitting like that, half in the trachea and half into a tissue plane.
So when you looked in with the bronchoscope, you just saw
I
tissue
saw like
wall,
a tracheal ring up here, and then I kept going, and I actually did go into a tissue plane in the mediastinum.
Yeah.
And then we pulled out and stopped, and then we just did a bedside trach change out.
Yeah.
But that's the only experience I've had.
But yeah, no one's it's so tempting to put that in, and you just resist that urge, is what I mentioned. So sometimes ENT leaves like these stay sutures and special strings like a puppet, and they might be able to come by and pull this off and put that in, and you don't have to don't mess with that. Your answer, like for board's questions or for your call tonight or life in general, any kind of ventilator, alarm, patient ill, take them off the ventilator and bag them 100%, so then you don't have to worry about the machine malfunction. And then if you still can't bag them, you have to look at replacing the airway or putting in a new airway. That's the A and the ABCs. All right, so you have all the primary literature. You're pretty old, but that's why you do the things you do every day on rounds, or you will do them on rounds in terms of liberation from the ventilator. And then some troubleshooting. Any other questions or comments, other things you've seen differently? Now the ventilator rehab place, they'll do a pressure support wean. Maybe they'll do a rate wean, because they have like months with the person to slowly get them off the ventilator. But for our purposes, it's the spontaneous breathing time.
I'm talking about a fresh trach.
Yeah.
Is that less than, what's your time frame? I've used like
My guess is like 2 weeks.
Oh, really?
To have that granulated tissue and but I'd probably ask an ENT person. Again, they might have a lower threshold. They would probably feel comfortable putting it in. But for our purposes, if they're getting it in the ICU, they're probably not healing so well anyway because they're sick. They might say a few days, but I'd say 2 weeks. And for your standpoint, it's never wrong, to cover the hole and bag the patient, orally innovate. You'll never go wrong there. Good. Any other thoughts or questions, comments? All right. Well, congratulations for the guys finishing up. Welcome to the guys.